So what should be the goal of therapy in inpatient? So we need to understand three important studies in this field. The first comes this Levon surgical ICU study way back in 1980s or so. They did it on about 1,800 patients. Predominantly 65 or 70% of the patients were non-diabetic, and a few percent of there will be 15 or 20% of them were diabetic in this study. 1,600 patients or so, where what they have tried to do is they tried to do aggressive control of blood sugar to about 110 or so. They maintain the blood sugar about 110, and in the non-aggressive arm they try to maintain the blood sugar about 180 or so. So approximately around this range was the one which was maintained. So what they were able to see in this Levon's study is when the patients were aggressively managed to a blood sugar of less than 110 or so, they were associated with outcome of the surgical procedure, infection which was happening, the stay which was happening in the surgical ICU, the mortality risk, the other comorbidity complications that was happening, the infection which was happening. So every other parameter, when the patients were aggressively treated, aggressively treated for the sugars, when the blood sugar was kept at a very tight range of 110, it was associated with a very good outcome. That is what they showed in Levon surgical ICU study. And again this study, they went back to medical ICU also, and they were able to show even in medical ICUs, this sort of aggressive management was helping the patient. That is what we learned from this Levon surgical and medical studies. But after this, there were various meta-analyses, there were various studies which were not able to prove such sort of aggressive management is helping the patients at all. And the most revolutionary study came in the form of NICE sugar, which was published in around 2008 or 2009 in NEJM, where they were able to see like the patients were maintained to a sugar less than 108 milligram per deciliter, something like an aggressive arm of the previous study, and the patients were maintained between 81 to 108. They were able to categorically show that when the patients were aggressively treated, so the patients were aggressively treated between 140 to 180. These are the patients who were associated with a better outcome than the patients who were kept in the fixed arm or in the patients who went for a lower sugar in this arm. So they were able to show the comfortable blood sugar range for our patients when they were treated in inpatients or in ICU is between 140 to 180. So this was associated with a good outcome. Rather, when they were treated more aggressively, the complication and mortality risk was increasing. So the NICE sugar showed that such sort of aggressive management is not warranted. And a factor which was attributed to this study is because of the use of the parental nutrition over here. So whether it was associated with this parental nutrition, it was showing this sort of study. They wanted to clarify. So what a similar study by the similar group came in the form of TGC FAST study, where in this group the parental nutrition was not needed. This is a very recent study which was parental nutrition was not needed over here. So in this study, what they tried to do was they were able to get two arms. One is this aggressive arm and one is this liberal arm where the blood sugar was kept 250. The patients didn't need parental nutrition. So this was published in 2003 in NEJM. So in this study, what they have showed was even a level of 215 was not associated with an adverse outcome than this aggressive management. So this was more beneficial for most of our patients because managing at this level was becoming very, very hectic, very, very difficult. No way it was proving superior than the other arm, and it was requiring lots of effort from the hospital staffs, the ICU doctors, everybody, and monitoring. Everything was becoming hectic. So this sort of aggressive management is not needed for our patient, and it shows that even 215 might be okay for our patient. So as far the goal is concerned, 140 to 180 as per the NICE, and TGC FAST has said like even 215 is acceptable for most of our patients. So we can be still more liberal. So the target should be around 140 to 215 based on these two studies. So this is what the target has to be. So when it comes to inpatient hyperglycemia between OHS and insulin, so OHAs are a big no. As far as possible, that we have to shift them patients to insulin. But in some circumstances, still OHAs might be okay for our patients, because if the patients are coming for a very short procedure, surgical patients, for a illness like where we think that the patient need not be converted to insulin, still we can manage them on OHAs. But remember, the thumb rule is, as far the inpatient hyperglycemia is concerned, it is all about insulin always.